and because we do take any comments that you raise really seriously, so thank you. And as I've already mentioned, if you want to use the chat function, please feel free to do so. And what we'll do is we'll facilitate that throughout the session and answer any questions in the chat box. Next slide, please. So this slide is just a summary of some of the feedback that we received at the last event. We had people that were saying thank you, the session was informative and helpful. One participant said that it was easier to hear some of the participants than others. So please, if during any of the speakers, if you feel as though you can't hear, just drop a comment in the chat box and it'll just draw our attention to, to the fact, and we'll try and speak a bit more clearly. And somebody also commented that they didn't have any problems with the technology this time. 100% of people who completed the questionnaire said that they had sufficient time to express their views during the meeting, and a percentage of respondents rated the items as either informative or very informative. And what we've done is we've just put some of the key highlights there from the Survey Monkey. The next slide, please, Jake. So this doesn't seem to be displaying properly. Yeah, what we've done here is it's not displaying properly on Teams, but what we've done is we've just included some demographics of on the attendees, such as age, race, gender, whether the person attending the session has a long-term condition or a disability. This isn't displaying on the presentation properly, but it will be included in the slide pack that we send to you. So that takes us on to the next slide. And this is where I'm going to hand you over to Mark. Mark, are you there? Just like to introduce everybody to Mark, who's our Associate Director for Transformation, System Resilience and EPRR. And Mark's doing a presentation on ICS in place and the move to place-based working. Hiya, Mark.
Hiya, Kirsty. Can you hear me?
I can do. Thank you. Right. I'll hand it over to you. Jake's controlling the slides. If you just let him know when you need him to move on.
So I just want to give a bit of a background to terms that you've probably heard a lot about: integrated care systems, integrated care partnerships, and place-based working. So over the last couple of years or so, there's been a lot of discussion around the North East and North Cumbria about how healthcare will be reformed and delivered going forward. So I think there's some major changes that we're going to experience over the next year to 18 months, and how we will work together collaboratively is still up for debate and discussion. However, we know very much that we will have an integrated care system which covers the North East from North Yorkshire all the way up to to the borders. And we'll have a population of around 2.5 million, which we'll have to serve. So I'm going to take you through. I've got a number of slides which I don't plan on going through in great detail. They're there for information, and I'm happy to take questions at the end. So Jake, would you mind moving on to the next slide, please? Previous. That's it. Okay, so 1948 NHS was set up, and it was primarily as a national health service, and it was designed to provide episodic treatment of care around acute illness. Now, clearly things have changed over the last few decades and generations, and as a result, we now need to work very, very differently to ensure that we provide care for acutely ill patients, as well as provide treatment and manage long-term conditions, as well as prevent and intervene early to ensure that patients and residents don't become unwell. So the white paper published in 2021 identified and laid out legislative proposals for a new health and care bill, which will come into force in 2022. So a white paper simply identifies the proposals that the government is making before it goes through a number of readings within the House of Commons and then Lords, and then receives royal assent. So there's a bit of work that still needs to happen. Next slide, Jake, please. Okay, so the integrated care systems are partnerships that bring together providers and commissioners of NHS services across a geographical area. The ICS, North East ICS, is the largest integrated care system in England. and they do vary in size between a population of around 250,000 to the northeast, which is around just over 2.5 million. So significant differences. What we do have in the northeast is I say use the word significant, a record of working collaboratively together across all of our foundation trusts, our ambulance service and other major providers to ensure that patients can access the care that they need and have the care provided them. Either from a local authority point of view or from a healthcare point of view or any other care organisation in the most effective way. So Jake, if you flick, please. Okay, so we've got the map of North East and North Cumbria, which includes all of the CCGs, so Newcastle, Gateshead. So the North ICP, so you've got integrated care system, which covers all of the patches. You've then got 4 integrated care partnerships, which is the North, Central, South and North Cumbria. And then you've got a number of place-based areas. So specifically for Newcastle Gateshead CCG, you've got Newcastle and you've got Gateshead place-based system. So from a North point of view, we've got just over a population of 1 million. We've got 3 CCGs. We've got a number of newly developing primary care networks, as well as our already well-established foundation trusts, already well-established GP practices, community pharmacies, and a whole host of other organisations which work together now. I think what's driven a number of these changes is the fact that patients don't necessarily access care within the local geographical area anymore. So we've certainly got a number of patients who access care who live in Gateshead in Newcastle and vice versa, and also will access other specialised care elsewhere within the UK. So there's a rationale for the changes. So moving forward again, Jake. So the aim of the ICSs are to integrate care across different organisations and settings and joining up hospital and community-based services. So a good example of the work that we've been doing recently is ensuring that patients can access hospitals within our ICS, the North East North Cumbria area. When we've got significant surges or high levels of escalation, we do experience patients who aren't necessarily taken to the nearest hospital. They either go to the hospital for particular care or specialised care, or where particular organisations are busy, a patient will be taken to another hospital to ensure that they can access the right service very, very quickly, i.e. a hospital bed. Now, clearly that brings together problems when we have to repatriate patients back or bring patients back to their own local community-based services, or where we have to then ensure patients can access the next stage of their pathway of care, again, which causes significant issues in terms of transport, accessing the bed, how we refer into community services, how we refer into follow-up care such as physiotherapy or alternative therapies. So we're already managing that now on a large scale. We're well versed in that. But from a national point of view, we know that other areas don't have that same level of coordination, collaboration and relationships that the North already have. So what I'm trying to say, basically, it's nothing new to us. Move on, Jake, please. Okay, so as an integrated care system, as I've said, it's nothing new, and we've worked collaboratively for a number of years now, since really CCGs were established under the Health and Care Act of 2012, to ensure that we've got a shared view between system partners of what the local needs are and the resources available for healthcare. So, for example, we've got one North East ambulance service which covers the whole of the region, and we have got to work, all of our CCGs who commission that service, we've got to work collaboratively to ensure that we get a standardised service offer from the North East Ambulance Service, and any issues that may arise, we work together as a system to benefit all patients and all residents. We don't just do it in splendid isolation. What we do, though, is agree a local strategic direction. So, for example, whilst the North East Ambulance Service, and it's probably the best example, whilst the North East Ambulance Service deliver 999 and the 111 service, what we've got here locally in Newcastle and Gateshead, for example, are a number of service delivery models, a number of locally commissioned services to ensure that all of our local needs are met most appropriately. So we've got, for example, in Newcastle Gateshead, we've commissioned a falls car where we've got a paramedic and an occupational therapist who will provide rapid response to frail and elderly patients or any patients who may fall in a care home or in their domiciliary care or at home, to ensure that that patient isn't necessarily taken into hospital That isn't a priority for other parts. That is something that we've decided to do locally because of some of the public health outcomes and some of the rates of admissions that we've got for fracture neck femur, and also the high rates of falls that we've got. So we've prioritised that, and that's a really good example of how we've got a contract which covers the ICS, but we've been able to develop that locally based upon our local need. We work together to establish a local infrastructure and agree how we're going to work collaboratively, for example, by putting in place new governance arrangements. So here in the north, in Newcastle and Gateshead, we've got a number of project boards, operational groups, and where it would benefit, for example, around urgent and emergency care, we've got a North ICP, which is made up of Northumberland, North Tyneside, Newcastle and Gateshead board, which covers off patient pathways, where services cross over into different geographical locations to ensure that we can commission and plan services in the best interest of our patients. So we've got multiple examples of where we are delivering at ICS, at ICP, and also place. But what we have noticed is, as a result of this way of working, again, it's further enhanced our collaborative way of working, our relationships, and the trust that we now have between partner organisations and their leaders. I'm not talking out of school. When I say that, over the past few years, some of our acute trusts haven't really had the best relationships. We've massively improved those relationships now, and we've overcome a lot of the issues that we've had, simply because we work together, we speak together, and we've got common aims and objectives and common goals that we want to deliver to achieve. So it's been really beneficial, the way that we've been working recently. Next one, Jake, please. So what does it mean for CCG? So clearly, clinical commissioning groups were established in April 2012 under the Health and Care Act. These will be abolished when it gains royal assent. So it's likely to be April 2022. So their functions and most of the staff will transfer into the ICS. It will become a statutory body. The ICS will also take on some specific commissioning arrangements from NHS England. NHS England is currently responsible for directly commissioning some specialised services, such as neonatal services or treatment for certain cancers, or commissioning things at scale, and also responsible for co-commissioning, along with CCG's, primary care and GP practices. What CCGs have also been working together collaboratively at a place-based level is with local authorities to align and integrate commissioning for NHS and local authority services. So if we think about patients being admitted in a hospital, patients receiving the care that they need within hospital, and then importantly being discharged out of hospital to their normal place of residence, i.e. their home, or to care homes or to other local services, we can do that much more effectively at a place-based in a place-based approach, because we've got all of the key partners around the table. So again, that are some of the things that we're going to work through as a result of the abolishment of CCG. So we've also now moved some of our CCG staff who've now got place-based responsibilities into Newcastle and into Gateshead, and we're also starting to align our planning and work through some of the common priorities that we as a place-based system need to address and develop and commission new services for over the next year or so. So moving on, Jake. Okay, so ICS is very much in the news headlines, but the primacy of place is widely recognised, with a general consensus that around 80% of services will be designed and delivered at place, i.e. within Gateshead and within Newcastle or Northumbria or North Tyneside, with decisions taken as closely to the local communities as possible, involving scrutiny committees and any other patient representative body to ensure that what we're designing and commissioning really meets the needs. And the evidence consistently shows that it's not just health impact, it's the wider determinants, as in the homes, the financial resources, the opportunities for education and employment, the communities in which patients and residents live, have a real impact on health and well-being, but importantly, access to public services. And we're starting to see that significant issue arising as a result, for example, of seasonal flu. We see, and COVID vaccination, we see certain communities who will rapidly and easily access those vaccinations, whereas we'll have some others who are hesitant or won't necessarily know the benefits or why they should have access to those services. So there's a lot of work that we can do and will do at a place-based level to ensure that we target our resources at those most in need, and we ensure that we've got a standardised and consistent approach to ensure patients have got access to healthcare wherever that may be. We know that we've got significant health inequalities. We know that we've got significant life expectancy reductions. But importantly, we've got significant issues around quality of life. And that's something that we can only address and work through locally within place. Next slide, Jake. Collaboration isn't easy. We know that every organisation has its own aims and objectives. Every organisation has to balance the books. And clearly over the past few years, we've had some significant discussions around funding of care, packages of care, and also access to health service to ensure that what we've got is consistent. We aim to address that at place. System is subservient to place because place is where people live, and that's very much a mantra that Newcastle Gateshead CCG are embracing. And as a result of, as I've just said, we've already started to move staff towards place, to start to develop the infrastructure, to develop the way of working, to integrate with local services such as the local authority, and ensure that over the next year to 18 months we're in a better position than others to deliver the care that is required. And that's understanding the health inequalities, understanding the health needs, undertaking equity audits, understanding the health needs of local patients and residents, to ensure that we can develop our own strategic aims and objectives so that we meet the needs of patients. Next slide, Jake. I'm going to move on because I think I've covered some of that off. So if you go to the next slide. Okay. So from a place point of view, it's a real opportunity to join up health and social care at all levels to create better outcomes. There's a potential to improve population health and wellbeing through the leadership of public health teams who sit within the local authority, as well as bring together the NHS and local government. The involvement of local government can really enhance transparency and accountability, because in the past we've developed certain service delivery models or we've made some proposals. We've then taken them to our council colleagues and our elected members, and because some of those elected members don't necessarily understand the rationale or understand the potential, we've had a high level of scrutiny. What we're able to do is involve all those organisations, all those individuals right from the outset, so we make that journey an awful lot smoother. So clearly, democratic oversight is a key part of that, but we'll be able to do that right from the outset to ensure that we get a win-win situation. Next slide, Jake. So I think for me, there is 4 key functions of place-based partnerships: understanding and working with communities, joining up and coordinating services around people's needs. Next slide, Jake. Addressing some of the social and economic factors that influence health and wellbeing, those wider determinants that I've described, and also supporting quality and sustainability of local services to make the best use of the pound, supporting local workforce development and deployment, and also driving improvement through local oversight of quality and performance. So ensuring that we are meeting the needs, those needs that I keep describing, meeting the wants and the health and improving the health outcomes of patients and residents. Next slide, Jake. So working, both place-based teams are now starting to work through some key principles. So starting from purpose with it developing that shared local vision, building in new relationships with communities if we didn't need to, if we hadn't already done that, invest in building upon some of those multi-agency partnerships that already exist within Gateshead or Newcastle, which we may have overlooked, paid lip service to, or not given the right amount and due amount of attention that we potentially could have. Building up from what already exists, focusing on relationships between systems, places and neighbourhoods, and accepting that patients will access health services in different ways. So, for example, we may not need particularly to have a service in every ward or borough within Gateshead and Newcastle, but what we may need to do is focus some of our attention on some of the wards who have highest deprivation, highest inequalities, or the poorest health outcomes, rather than that standard approach of ensuring that we have one service model in each of the wards and boroughs. So there's real opportunities there. Strengthen the role of providers at place. We're bringing together commissioners and providers and key stakeholders in a way that we haven't done for many years. we're in this together is something that I've heard many, many times over the past few months, rather than I as a commissioner will purchase the services of an independent provider. And we've got adversarial relationships or have adversarial conversations. Hopefully we'll eradicate those, we'll get rid of those, and we'll really embed effective place-based leadership and effective place-based working. Next slide. Now, this is a slide which probably isn't very clear to us all, but what I've really tried to do there is just to show over the next year what the execution of some of the CCG functions will be. So the big circle oval shape on the right is the place-based teams of Newcastle and Gateshead, who are responsible for delivery, prevention, treatment and management within a local authority footprint, the operational delivery. And there's some key areas there around integrated care delivery in conjunction with key stakeholders, relationship management, commissioning of primary care, prevention, third sector providers, children, older people's care, mental health services, and secondary care with our local acute trusts. Providing that oversight and support, tackling inequalities, engaging with MPs and elected members, something that we haven't done particularly much of over the past few years as a CCG. We've done it when we've needed to. Again, as I already described, the opportunity is there right from the outset. Having oversight of primary care networks, the networks that we've got in each of the Gateshead and Newcastle, the groups of practices, which cover around 50,000 of the local population and residents, to ensure that we can deliver care at a level which is appropriate, and also ensuring that we've got some real place-based communications, key messages, and engagement with our local key stakeholders. The other two ovals or circles are really describing the ICP work, and that will continue to deliver for the next year, if not going forward for longer than that, across Newcastle, Gateshead, Northumbria and North Tyneside, around the continuation of the COVID management, the coordination of planning, having that system oversight, particularly around services such as NEAS or Cumbria, Northumbria Mental Health Trust, Tyne Mental Health Trust, and where we've got pathways of care where it would be beneficial to collaborate. So urgent care is a good example, or specialist care provided by Newcastle hospitals. So that type of service delivery models. And at an ICS level, again, the coordination and planning, the tackling the inequalities across the region, the prevention, the climate change work, the economic activity, and commissioning at scale where it's in its best interests to do that. So that's, I hope you have shown for the next year, 18 months of some of the work that we'll have to do. So next slide, Jake. So again, very much I've given you from a statutory point of view what we are having to deliver, but I just wanted to remind us all a lot of the patient feedback that we've had throughout the, not just the CCG, but any event, any patient engagement process that we go through. So just flash them all in, Jake. I know they're on they're coming up one by one, but if you could just get them in, that would be great rather than going through bit by bit. Yeah, great. So I'll go back. Yeah, so when I'm in need of care, it's safe and effective. I'm able to see the right health professional at the right time and in the right place. I want to be helped to be healthy and active. I can expect the same healthcare outcomes wherever I live. I want to be helped to be as independent as possible in the best place for me. I want to have a good experience and be treated with respect to dignity. Those are some of the key themes that constantly come through and are fed back to us in any patient feedback and engagement process. So clearly it's a priority from a place-based level as well as an ICP, as well as an ICS. So they will be very much at the forefront of any service delivery model. And the next slide talks about some of the place key priorities. So I'm bringing to you some of the key discussions we've had from Gateshead now. So just bring them in, Jake, as well, please. So shifting the focus of care from treatment to prevention, increasing self-care and health and well-being, providing care close to home, collaboration, go back, I can't remember them all, collaboration with system partners to deliver equality and efficiency, new ways of caring for people with long-term conditions, digital interoperability to improve patient flow and information flow. So ensuring that wherever you present as a patient, your clinician or carer will have access to your health records to provide that best level of care. Access to the highest quality and sustainable primary community urgent and emergency care wherever you present, reducing deprivation, inequalities and social isolation, establishing a flexible and collaborative approach to workforce, caring for frail elderly patients, and also mental health service development. So it's not just about the physical health, it's about the mental health. So what I hope I've described there is ICS. I hope I've described to you ICP, and also the role of place-based teams, the Gateshead teams, the Newcastle teams, about how we will continue. I think what is clear is there is a connection at all levels. There will continue to be that connection. ICS will have oversight of healthcare across the northeast North Cumbria. It will join up different acute services, different service providers, where there are economies of scale. But the primacy of place will be very much prevalent in that we will be working with our local residents and patients to ensure that we develop, deliver and commission healthcare where it's needed at most, and then ensuring that patients can access the care where they need that. So I'm quite happy now to take any comments. Sorry, my camera hasn't been on, but my IT isn't working particularly well. So happy to take comments now. One thing I've avoided is looking at the chat box because I think I just want to get through the presentation, so I'll pick up that. Okay, so any queries? So David, so I'll pick up the point that you've raised there. So Collaborative Newcastle, clearly that is a model which has been developed within Newcastle footprint, where all providers and stakeholders have come together, and in the same way that we have done for the Gateshead care model, where we've got all key stakeholders working around the table now to ensure that we develop priorities, work with our local groups. It embraces all key stakeholders, it brings together that care, and to be fair, it's something that we've had in place now for several years. So again, I'll repeat, it's nothing new to us. All it's done is given it the ICP, ICS, and place-based is given us that statutory footprint to work together at those three levels to ensure that we deliver care in a way which is integrated and joined up, because we haven't necessarily done that in the past few years. Right, no questions, good. Move on, thanks very much.
Terry's left a comment in the chat box, Mark.
Yes.
Terry said, place is becoming a problem word. It is used for different levels at different times. Newcastle PCN's a provider. Do we need to look at that?
So place is simply a term which is used very much within the white paper. It describes a population. So we've got primary care networks, which we have five in Gateshead, and 1, 2, 3, 4, 5, 6 in Newcastle. I think that's right. Dominic, help me out there. But we've got primary care networks, which are a population of around 50,000 patients who are registered with a group of general practices. Place is Gateshead. It is also Newcastle. The CCG, clearly statutory till next year, is Newcastle Gateshead. But I think you're right. We need to be clear about what the word place means and how we ensure that it represents what we're actually delivering in Gateshead. Simply, to me, it encompasses all key stakeholders and providers who deliver, and all residents and patients who live within the Gateshead footprint or the Newcastle footprint. But yes, we're talking about terminologies.
Thanks. I'm just looking up the comments in the chat box from the beginning. David, you've kindly left some background to you, and you've also commented on your Twitter account and the work that you're doing. So thank you very much for sharing that, David. It's appreciated. David also asked what EPRR stands for, and he's put a link to that, and that's emergency preparedness, resilience and response, and that's just one element of your job, isn't it, Mark?
Yeah, so EPRR is our statutory responsibility as a Category 2 responder. So Category 1 responders tend to be blue light services. Category 2 responders is a responder who is responsible for ensuring safety, responding to any incidents, responding to particular surges and pressures within a provider organisation, and ensuring that all commissioned service providers has business continuity arrangements.
So the next question was off David, and that was Collaborative Newcastle North of Tyne combined, and you've answered that one. Mm-hmm. Then was Terry's question, you've also answered that one. And then there's another comment from Terry. Not sure David's definition is what the average patient sees as place when accessing care.
I think we're getting into a language which is people have different understanding and different views. I think what we need to focus our attentions upon is Gateshead and Newcastle, and ensuring that the residents of those geographical locations can access the services in a way that is easy, it is appropriate, and where care can and needs to be provided or accessed outside of Gateshead and Newcastle, we provide every opportunity to do that. So again, that's the pathways, the effective pathways I was describing. So let's not be too inward focusing towards the Gateshead or Newcastle players, but let's look at how we can work together as a local system, which includes social care, which includes all other providers, to ensure that we provide an appropriate response.
That's lovely. Thanks, Mark. Does anybody else have any further questions or need any further clarity? Either could you use the chat box or raise your hand, please? I don't think anybody has any further questions to raise, Mark, but if anything comes up through the rest of the afternoon, we will get in touch and let you know.
Yep.
I'd just like to say thank you very much on behalf of the group for attending the session today. I'm sure they've all found it really useful, and I for one found your presentation really helpful. So thank you, Mark. It's appreciated.
Thank you. No problem. Thank you.
Okay, thank you, Mark. Right, and that moves us on to the agenda. We're slightly ahead of time, so Jake, that means if you need a little bit longer, that's absolutely fine. This next part is for Jake, and Ashma was due to join us today, but unfortunately she can't. So Jake's going to take us through the engagement update for both the Newcastle and Gateshead area. So Jake, can I hand it over to you, please, so that you can take us through your slides?
Sure, thank you very much. Can you hear me okay? Yeah?
Yeah.
Okay. Well, as Kirsty said, unfortunately, Asma's not here today, so the presentation split in terms of the Gateshead update and also the Newcastle update. I'll try and cover off both. So first of all, Gateshead. I'll just give you an update on some of the place-based work we've been doing in terms of engagement. I'll just move the slides along. So these are the selected workstream updates up to this month. First of all, children and young persons engagement. The group for Gateshead Place has been working well on a number of projects, meeting monthly, bringing together staff from both the CCG and Gateshead Council. Current projects include working with Valerie Ender at Gateshead Council to provide a voice opportunities recognition for young people across Gateshead. This month she's been working promoting the Young People's Awards to recognise children who've perhaps been stepping up to the plate and undertaking the role of a carer, for example, during lockdown for a relative, or have done other something else exceptional that is worthy of recognition. The awards are being made later this month, so try and keep you posted on that. Separately, Lauren Graves and the Children and Young People's team at the CCG are working to develop a teenage health resource similar to the successful Little Orange book that's already in use for younger children to support their parents and carers across Gateshead. Ultimately, the project will include resources to support teenagers on everything from mental health to body image, weight difficulties, bullying, smoking, sexual exploitation, drugs, alcohol. So a number of really pertinent issues that are current to young people. So that will be, when it's finished, a very useful resource. On mental health, I think it's fair to say that this is a particularly big priority for the Gateshead Place Directorate, both across the council and the CCG, as we see the real cost of this to our communities coming out of COVID. Kirsty Sprud and Angela Kumar have been doing some exceptional work on this front, developing the Community Mental Health Transformation Programme. So far, they've developed a vision statement for Gateshead Mental Health Community for the community model, working with both the community, voluntary sector, patient groups, both the Acute Trust and the Mental Health Trust. We've also appointed a programme lead who sits both across the local authority and the NHS. Work over the next year is going to include a complete review of the CCG and local authority commissioned residential beds. The aim is that we're going to ultimately improve provision. For example, we're going to see much closer working with housing, social care, voluntary and community organisations to improve housing and support for people with significant mental health issues so that they can better live semi-independently where possible. We're also going to be working with local authority to ensure patients with complex mental health needs have appropriate housing and support options provided when they actually need it, so that there's a reduced risk of homelessness, for example, on the back of a significant or ongoing mental health episode. And then finally, we're doing some work helping people, mental health patients who have been detained under the Mental Health Act after their discharge, so that once they're discharged, so that it can help in accessing personal health budgets under what's known as a Section 117 entitlement. So that basically helps them live better lives in the community once they're discharged from hospital. In terms of long-term conditions, we've got a very lively and friendly meeting group. It's a very active group. Some of you may indeed be members of it, so hello if you're one of the group. It's a patient-led group, and it's chaired by David Hewitson. Members have a range of interests and knowledge stemming from experience of diabetes, heart conditions, arthritis, etc. Sam Hood from the CCG was there to listen to what members of the group felt their experiences of GP surgery provision had been like for people with long-term conditions during the pandemic. And a range of issues were raised. Sam's agreed to take those concerns away and discuss with GP practices and colleagues and then report back to the next meeting. The group's also got its own WhatsApp group, which has been very effective at letting members discuss things amongst themselves in between meetings. It's also a popular way to informally socialise remotely too, I think it would be fair to say, so people are able to talk about their interests outside of the health issues and how the health issues impact on their wider lives too. And if anyone's interested in joining the long-term conditions group, please drop me an email and I'll let David, who's the chair, know. And then on problem alcohol consumption, we've got quite an exciting partnership with the ICS developing. This is a new partnership. The lead policy and research person, there's a person called Sarah Holtz. She's been responding to a request, or rather, we've been responding to a request from her, rather, to help them work on a strategic priority to increase regional rates of successful intervention with people who are basically at the early stages of becoming heavy drinkers. There's a separate program already in place to address people who have long-term history of significant alcohol abuse. So specifically, our involvement is to help the ICS evaluate this more early stage intervention program. So the study will first assess the impact of the initiative on a targeted group of patients and the public. And secondly, it's about exploring the views and perspectives of the public and clinicians more generally on what works and what doesn't work in terms of them accessing and acting on the advice. And then this will ultimately lead to some new policy recommendations and implementation for a wider rollout potentially across the North East and North Cumbria and areas possibly even beyond that. So it's quite a significant piece of work. And then finally, on the GP website review, actually, do you know, I'll say a bit more about that later when it is a precursor to the Newcastle slides. Let me just change over the Newcastle slides.
Before we move on to Newcastle, I wonder
Sure.
whether if anybody had any questions regarding the involvement work that's ongoing at Gateshead. Does anybody have any questions that they'd like to ask Jake? No. Right, no. Jake, if you can just take us
Sure.
on to Newcastle,
Sure.
then if anybody has any questions, you know, you can answer them at the end.
Sure.
Thank you.
Thanks. Yes, and as I say, unfortunately, due to illness, Ashma can't be here today to do the Newcastle update. However, I'll try and cover off some of the work that she's doing, and also touch on some of the other things that are happening in Newcastle in terms of engagement. I was actually at a very interesting meeting the other day with colleagues and heard a presentation from a person called Rob Henderson, who is working with Dan from Involve North East. I think Rob Henderson has been working with out of the Osborne Road surgery. And he's also with Jesmond and North Gosforth PCN on an NHS digital bid to improve GP websites. So far, they've undertaken a survey of patients to find out what they already like and dislike about their local GP surgery websites. The aim is to make them a lot more user-friendly, easier to access, more useful generally. They've collated and reported on the findings, and then the next steps are to take what is best from each so that the surgeries can improve both content and accessibility across the GP PCNs. So changes will include things like I think there's going to be some centrally populated information that then gets fed through into automatically updating the websites. And then there's so it'll all be coordinated across the group. And then there's going to be some improvements, hopefully, to the ease with which people can use the site for things like, booking appointments, because I know sometimes, depending on which surgery you go for at the moment, that can be a little bit clunky depending on the mechanisms used. So there's going to be improvements there. But also finding out standard information, because if people can get the information they want from the website, then they aren't taking up so much time on the phone with the receptionist potentially if it's a relatively straightforward, simple piece of information. So ensuring that the information on the GP website is pertinent and relevant and up to date. So in theory, that should improve the time that it takes to get through if certain inquiries are diverted that way. I also understand that Ashmar, sorry, I should move on to the Newcastle side here. I understand that Ashmar's also been working with Connected Voice and is beginning to work on programs that are designed to champion equality and amplify voices from the BAME communities. I understand we're also working with Harif Allies and have been holding meetings to discuss health concerns and issues that are BAME focused. Co-production is very much at the heart of what they're doing there, insofar that the initiatives are very much community led. Ashmar's also co-designing a flyer, I think, that will be disseminated through the voluntary sector, faith, community groups in order to promote the PPI work and more widely. On the vaccine inequalities front, we've been working with colleagues to coordinate feedback from the community as well as stakeholders in the statutory and voluntary sectors. The ultimate goal is obviously to increase the uptake of the vaccine, particularly in those neighbourhoods where uptake to date hasn't been quite as high as some of the maybe more affluent areas. We're seeing some significant variance in the uptake between neighbourhoods. We're now we're looking at targeting some pop-up vaccination centres. I know in Gateshead we've got one in the Saltwell, the Avenues area that's going to be coming online shortly, where we've had a lower than desirable uptake. It's specifically targeted at those wards where we know that there's a lower than average uptake. I think all I want to say at this point is that there is a marked correlation between those neighbourhoods that are particularly challenged as measured by the index of multiple deprivation and uptake of the vaccine. That's a statistically significant correlation that is shown in the data. So that's very much where the efforts are being focused at the moment. On the Neighbourhood Mental Health Transformation Project, I'm not going to say a lot on this, as I know Kate Bowman is on today, and she's going to be doing a presentation on some of that later, so I don't mean to steal Kate's thunder on that. I'll merely note that there's been an awful lot going on with neighbourhood and ward meetings for the areas covering North, Central and East, Outer West and the Inner West wards. On workforce development, I know we've been looking at current methods of recruitment and employment to see how we can improve the recruitment process for those who have protected characteristics, and then probably finally, actually, say a little bit in terms of Newcastle Send. The team is working with Newcastle City Council to develop and deliver a number of engagement activities with children, young people, and parents. The work is about how we can better include the voice of the child and embedding their ideas within the services commissioned by the CCG. So specifically, that's involving things like co-producing a forward plan for consistent engagement with children and young people, and hosting some engagement workshops with children, young people, parents, and carers. I think I've already covered off the diversity and BAME work. There is a as I say, Ashma's already designing a leaflet that will be distributed amongst different faith-based communities. We've also got an online sign up as well that we're pointing people to. So if people do want to get more involved with meetings and events and so forth, we can signpost them to a form that is on our website that is literally just going live. Okay, I think thanks for that. I'll hand you back over to Kirsty unless anyone's got any questions.
Does anybody have any questions that they'd like to ask Jake about any of the engagement work that's going on at the moment? No, I don't think there's any questions, Jake. So thank you for that. And I think it just shows some of the good work that the team are doing both across both Newcastle and Gateshead. So what I propose that we do now is we take our break and we'll resume at 3:10. So we'll have a 20-minute break instead of a 15-minute break. After the break, we're going to have a presentation from Kate, and then Dr. Dominic Slowy's joining us at 3:30 to give us an update on the current position with regards to COVID. So what I'll do is we'll see you all back here at 3:10. Whilst you're on your break, can you please put yourself on mute and turn your camera off? Go and have a nice cup of coffee, and I'll see you all again at 3:10. Thank you.
Yeah? There's some in my cup.
Hello everybody, welcome back. What I'll do now, I'll hand this over to Kate, who's going to be giving a presentation and understand what is important to the community when it comes to mental health and mental well-being. Kate, I'll hand it over to you, and you've got till 3:30 till Dominic joins us. So passing it over to you, Kate.
That's fine, thanks. I'm going to take my picture off in a minute, just so everyone can see me at the beginning, because sometimes my my signal isn't as good as it could be. But Jake is very kindly going to manage the slides for me. So hi everyone, I'm Kate Bowman, and to be honest, I know you'll all associate me with Newcastle City Council and the website Information Now. But really today I'm representing the Newcastle Collaborative and the mental health transformation. Not that I'm a leader in it, I'm just one of the people taking part in the work that's going on. I put in the chat a link so you can find out more about the Newcastle Collaborative, because it was only set up last November. And I've also put a link to the Information Now article on mental health, which I think you might find useful. So I'm going to turn off my picture now. And if you wouldn't mind going to the first slide for me, Jake. So I'm not going to go into a great deal of detail about the Collaborative Newcastle partnership, other than to tell you that it includes the Newcastle Hospitals Trust, the CCG, Newcastle City Council, Cumbria, Northumberland, Tyne and Wear Mental Health Trust, and GP Services in Newcastle. They're the main partners. And essentially what they want to do is bring together a more integrated way of supporting people in the city and supporting more of a prevention agenda, which actually is what Mark was talking about earlier as well. So we're all keen to look at issues and prevent them and preempt them, rather than let them get to something that is much more serious to somebody's health and well-being. So the vision for the community mental health transformation is to improve the health, wealth and well-being of Newcastle's people, and to reduce the widening inequalities that too many citizens experience. So Mark's alluded to that earlier as well. Our health inequalities are really high. In Newcastle, our life expectancy, for instance, is shorter. We have more long-term conditions, and so it goes on. So what we want to do is focus on prevention and find ways of tackling things before they become much more serious. Next slide, please, Jake. So the vision really is to bring partners together and create more sustainable solutions, and to improve accessibility and choice, and make more of what we offer, open access. So any of you who've tried to get into a mental health service probably knows that they've had to be referred. It hasn't been easy. You might have been on a 6-month or a 9-month waiting list, and that you will get a package of support, 6 weeks, 8 weeks, etc. And then you have to move on. So you're either moved on to another service, or you're moved on to look after yourself and considered to be on a sort of self-help road to recovery. But we all know life isn't that simple, and our ups and downs come and go all the time. So it's really important that we create not necessarily just services, but support mechanisms that people can access in different ways. And we particularly want to make that local accessibility. So think in terms of your neighborhood or your community hub that you might have, but also sort of try and make more of that word of mouth as well, which we all know is so important. So we want to build on community strengths, make sure everything is much more person-centered and more holistic. I think one of the big things that's been recognised, and you'll see that when I talk a little bit later on, is that, as I say, people come in and out of a sense of well-being, and we all want to create that sense of well-being in all of us. But things happen. So we have problems with housing. The roof has a leak, you can't afford to pay for it. Lots of different things put stress and pressure in our lives. And we need to find ways of becoming more resilient. But that isn't about necessarily accessing a mental health service. It's about accessing support networks, peer support, and well-being support. And maybe some specialists along the way to do with housing, Citizens Advice Bureau, perhaps, that sort of thing. So it's much more about that. What we want to do is create those sort of hubs, whatever those hubs mean. So it could be a community of interest, but it could also be a place, and engage with residents and local groups to know that that new type of resource exists. So essentially, we want to empower people to make choices and access the support they need when they need it. Next slide, please, Jake. So here's a sort of very busy slide, but I suppose what it's trying to show you is that, you know, the palette and the picture is different for everyone. So, you know, there is a certain amount that we can do by helping ourselves, but we can only help ourselves if we know what's available and where it's available. And of course, that's where I come in with Information Now. My job is to provide that signposting service for Newcastle. But we want also to develop people to create their own coping skills and to live independently, and find out what's available locally to help and support them. Next slide, please. So I suppose the Newcastle programme approach is to test a series of different ideas, and I'm going to go into those ideas in a minute. So we have a vision, we've got a sort of an ambition where people are supported better, can come out in and out of services easily without barriers being raised, in and out. Oh, you've had your 6 weeks, or you've had your 3 weeks. Oh, we can see that 2 years ago you had support, so we can't help you now. That sort of approach. We want something much more seamless and much easier to support people. So what we're looking for is to create a series of try and test pilots, which we will analyse and see if we can come up with new approaches to mental health transformation, but with an emphasis on well-being. And I think that's come out particularly through this COVID period. Next slide, please, Jay. So we've got 4 try and test groups. They're locality groups, and It says here that they have close alignment with the PCN areas, and I suppose that's true. But actually, Mark was wrong earlier. We've got 7 primary care networks in Newcastle and 4 locality groups. So you can immediately see that some are going to cross boundaries because there are only 4 locality groups. Central and East, Inner West, Outer West and North, but they are aligned with the children and families locality groups. And I think that's quite important because some of this mental health and well-being work that we need to do is around families. So it's important that we have some alignment with what else is going on. Next slide, please, Jake. So I'm going to go through each of the try and test groups and what they've decided so far. So just to be absolutely clear, we only started this work in March this year. So we're very much in the infancy of this work. But we do meet regularly. So every 2 weeks, I'm in one of these meetings, if not 2 of these meetings in a week. So it is really busy at the moment. And I'd just like to say that organisations that feel that they contribute are really, really welcome at this point. And, you know, when we can get to the testing stage, we will be letting the public know much more about what we're going to do. So for Central and East, and the names of the leads and the email addresses are on the last slide because I can't always keep them all in my head. But Central and East, I think, is Liam, and he's from Concern Group. So they are a mental health charity. And at the moment, they've decided they want to focus on mental health for people in the homeless population. So you can imagine they'd be working with Crisis, Joseph Cowan, that sort of group. They're going to work with that homeless population to look at what the barriers are to their mental health and well-being, and then look at new presenting findings and next steps. Then from a GP perspective, we're going to look at the complex needs of some people, so much more serious complex needs. So, you know, bipolar, things like that, where we've got schizophrenia. There are a lot more complex need cases, and the GPs would be looking at how to develop a model to improve that for people. And then we had a lot of discussion in all the groups about what's happening in Newcastle at the moment. So at the moment, we have about 40,000 people who are using food banks and free food services. And that's an enormous part of our population. And I've been very involved in that because of all the food bank information is held on the Information Now pages. So what we want to do is work with one food bank, probably the West Food Bank, because they've now diverged and opened another service in the East. And we'd like to work with a food bank to try and find out what we can do to help when people are coming through that as a hub, and whether there are things where we can start picking people off and directing them to more local community support. I'll give you an example. St. Robert's Church now has somebody who supports mental health and well-being specifically, and I don't mean the priest. So, you know, they're bringing in services left, right and centre to try and support people in their communities. So West End Food Bank might be able to avail themselves of the support from St. Robert's Church. Next slide, please, Jake. So Inner West, there's more of a focus on what can we do in community hubs. So you identify your community hub. So you might say the Sure Start Centre at Nunsmore or something like that. And are there services that we could create where people drop in and they can have a chat and get a little bit of help there and then, but perhaps then get better signposting to services? Certainly in Inner West, we have the Angelou Centre, West End Women, and a number of other services. And we know that we have difficult to reach groups, and that's evident through the COVID vaccination as well, as you probably know. We are struggling to get certain people to engage with local authority and NHS involvement and perhaps trust. So what we need to do is harness the expertise of people who work with specific communities like the Black, Asian, minority and ethnic communities and get their help. But also there's a big movement to get more help for people who have suffered domestic abuse or harassment as well. So what we're looking at is community hubs and how do we use them? How do we work with specialists in this particular area? And then how do we develop the skills of staff and voluntary people to support social prescribing and help people better find the well-being support that they need? The next slide, please, Jake. So Outer West, you can see some of them are really going for it here. I don't know how we're going to achieve all these different things, but let's see. Some of this may find that it naturally sort of becomes one single piece of work. So obviously I'm very involved in the mapping of community assets in the Outer West. And we've identified somewhere like the Leamington Centre, where there already are formal services like Healthworks available there. And we might build other drop-in services that are there throughout the week to help people. In particular, we want to develop the idea of peer support as well. So peer support is where somebody who's had a mental health or a well-being or a debt or a marriage breakup sort of background might help somebody else to get to the services and the support that they need. And it might well mean peer support networks. Now, our specialists in this city on peer support, I suppose, would be thought of as RECOCO. And I always have to look at what RECOCO stands for, but it's the Recovery College Collective. It's run by Alistair Cameron. And it's a place where people who have experienced mental health difficulties come together to develop connections and work together to help others. So it's very much about building your own resilience and helping others build theirs. And we're going to be working hard with RECOCO on this particular Outer West development. Next slide, please. And then in the north, I've had less to do with the north, so I'm less familiar with this one. They've decided that they want to focus around older people and dementia and look at how we can help people better. So you will probably know that in this city we have two initiatives. One is the Dementia Friendly Newcastle initiative, and our key service is from the Dementia Advice Centre, and we have one Admiral nurse, Jo Costello. So we will be working with that group particularly to develop any support for dementia. And then in older people's terms, we've got Search Newcastle and we've got the Elders Council who support people who are older. But this is more about looking at mental health and well-being and addressing issues of isolation, loneliness and access. So we all know that a lot has moved to digital access. Well, we need to move beyond digital access as we come out of lockdown into something more accessible for people who aren't digitally equipped. And then their other group is students and young people. So what they want to do is look at what are those issues for younger people, and social media and the need to look great, feel great, be seen as a positive individual seems to be an enormous pressure on young people nowadays. And you'll see that they specifically identified issues with eating disorder, and it's absolutely true. I mean, the Newcastle Eating Disorder Service was inundated in the last year with need for help and support. So these areas are really very vitally important, and we need to work with the specialists to develop a service which allows people to go beyond specialism to general well-being, where they're connecting with their communities and feeling confident in their communities. Next slide, please. And then obviously, as we've done all of this work, we've identified that there's a lot of things that need to be done citywide. We can't hive off a bit of inner west or central or north to do what we want to do. So we've agreed that across the city, we need to do something around serious mental illness and personality disorder. And that will, of course, be led by CNTW, our mental health trust. But we also need to look more generally at community rehabilitation. So once you've been into those services on either the wards or the inpatient services, you know, at St. Nicholas or something like that, we need to look at what do we offer in the community to help people reconnect with their societies and their communities again. And then, of course, we know that physical health conditions do bring with them some mental health conditions. So being overweight, suddenly the onset of diabetes, finding that you've maybe had muscle wastage because you've been a bit scared to go out, or you've been told not to go out in the last year because you were keeping safe, means that a lot of people are feeling a sort of anxiety and fear that they may not have felt before about going out into Newcastle again, any part of Newcastle. And so we need to look at that and that link between mental health and physical health conditions. Now, we do have a number of crisis services through the City Council, and you'll find them on that mental health link I've sent to you. But also we do have mental health crisis services in CNTW. But again, we want to look at a wider range of what crisis services might be available and how people get into them. In particular, I think we are concerned about access and the constraints that we put around that package of care that people receive. So that's where we're going to be focusing the citywide work. Next slide, please. So, I mean, in some ways, I feel we're very much at the talking stages of where we're up to at the moment. But hopefully you did see in the last 3 or 4 weeks that we have launched the Happy to Chat benches as a campaign, and you can download a poster and stick that on a bench and sit there and say that you'd like to chat. I have to say the only bench I know about is in Kenton. So if anyone has any ideas of where all the new benches are, I'd be really pleased to find out about those and put some information on Information Now. Because I think as we come out of lockdown and this uncertainty that we're all still experiencing, I think people who've been isolated and are feeling very wary would like to find that there is a place where they can go to reconnect. And these Happy to Chat benches are usually in parks and places that are out of doors. Our other positives are, of course, that we've had lots of collaboration, lots of partners are getting involved. And, you know, as we seek the community hub spaces or the expertise from different groups, we're bringing lots of people into this community mental health transformation. I think that's it for me. If you just go to the last slide, Jake, that just shows you the people who are leading each of those groups. But the overall lead and the writer of notes and facilitation is Aileen Bolton, and she's based at the Mental Health Trust there. And I'm sure the slides will be shared later if anyone wanted to get in touch with Aileen or anyone else. Thank you.
That's lovely. Kate, does anybody have any questions? What we might do, Kate, is have you back at a future event to give some update on these because there's a lot of work going on. So I think it'd be really useful to have an update at a future meeting.
Yeah, very happy to do that. And it might be better to focus on a particular area as the pilots take place.
Yeah, that's great. And we'll discuss it with the Stephen group and come back to you. That's much appreciated. Thank you, Kate. That brings us on to Dr. Slowey. Dominic, there he's here. Dominic, thank you for attending today's session, and I'd just like to hand it over to you to do the update on COVID and NHS service recovery. Thank you for joining us.
Thanks, Kirsty, and thanks everybody for asking me to pop along to chat about where we're at. So most of this Those of you who've been following the news will sort of be aware of where we're at. And the first two slides look extremely busy with graphs and tables and things. But the essential message is to sort of look right in the middle of that slide. And this is for Newcastle to start with. And just look at those sort of humps on the diagrams, and that has been our sort of COVID peaks, really. And the one in the centre is the number of confirmed COVID patients in hospital, in Newcastle hospitals in that first instance. So what we can see is that has gone right down as of June. And similarly, the graph next to that in the middle looks at those patients who have been really poorly and have needed either high dependency unit, that's HDU, or intensive therapy unit, ITU beds. And again, thankfully, that is well down. And if we just want to move to the next slide and have a look at the same pattern there for Gateshead Hospital. So it's a very, very similar picture in Gateshead with very low, almost sort of, I think the week before last, there was one inpatient in Gateshead with COVID. And as you can possibly see from the slides as well, there is good bed capacity now in both our hospitals, and planned care is restarting and has been restarting for some time, but with appropriate social distancing and infection prevention and control measures, which does restrict the speed of recovery, but our recovery is making good progress in comparison to the rest of the country. But the reality check on that is that there are now significant waits for most non-urgent and non-cancer related care, and they're going to be with us for some time, irrespective of what we do. But we will say a little bit about what we're planning to do and what we are doing to try and recover that position. So if we could just move to the next slide. So the first really important thing to say, because I think there's been some media misinformation nationally about this, is that our general practices, we have 60 general practices across Newcastle and Gateshead, have been open and have been doing face-to-face consultations right throughout the pandemic. So if somebody needed to see a GP face-to-face and it was agreed between the patient and their doctor that that was necessary for an examination or a blood test or whatever, that has been happening. I think some of the information in the media has suggested that general practices have been closed, which they absolutely haven't. And we are in a position, unfortunately, where general practice is extremely busy at the minute. But we are supporting our general practices across Newcastle and Gateshead to still continue to have that triage telephone call first. And many patients that I see are reporting that they like the convenience of being able to deal with over the phone or over video those situations that can be dealt with like that. But we are seeing more and more patients face to face for a variety of reasons. Some people with mental health problems prefer to see people face to face to discuss their problems and their treatments. And of course, sometimes you actually have to examine somebody. You can't really tell what the matter is over the phone. And we're bringing all those patients in. So I just want everybody to be reassured that none of our practices have been shut and they will continue to be open. But in terms of just being able to walk in to your general practice, we're still discouraging that because we don't want people to be catching COVID and the new variants by sitting in relatively crowded spaces in waiting rooms when there are other options. So it's not back to pre-pandemic, but it's certainly not closed. I've mentioned already that the COVID activity within the hospitals at the moment is very minimal. What we don't know, I guess, at this stage is whether that is down to the lockdowns that we're just sort of easing out of, or whether that is credited to the vaccination program. And I think the next month or so will tell us where we are and whether the Delta variant is going to pose another problem. But the key message around all of that is that please don't delay or hesitate getting vaccinations, and please encourage those people in your families and communities to step forward and get their vaccinations as soon as possible. So Gateshead and Newcastle Hospitals, theatres and wards stepping back up, but with the social distancing I mentioned, and we're doing this in line with national expectations, and in fact in Newcastle and Gateshead we're exceeding those expectations. We continue to do risk assessments and testing of people coming into hospital, and that is having a capacity impact, but we're trying to minimise that as much as possible. We are already providing additional weekend and evening clinics for day case procedures, and we are using the private sector as much as possible to support us in addressing any backlog. Trusts are still using the new technologies to consult, so virtual outpatient clinics are happening, and I think the last time I came on this call I mentioned the digital dermatology service, where people with suspected skin cancers can now have a dermatoscope, which is a very high resolution image, sent to the dermatology 2-week wait for an assessment and response even quicker than was previously the case. So we are using the crisis that we've faced to develop new ways of seeing and supporting patients, and I hope people are finding that on the whole positive. Though we do have some significant waits in certain areas, and I think that I will cover that on the next slide. We're still very keen to hear about people's experiences, and the trust themselves are talking to patients and working with groups to give them feedback on how the appointment systems are working, how the waiting list reviews are happening, and the prioritization of people on waiting lists is being reviewed all the time. So as I mentioned, routine and urgent referrals are going up. Not surprisingly, I think a lot of people sat on their problems to try and help the NHS during the peaks of the pandemic. So quite rightly, a lot of those people are coming forward now. And so our hospitals and our general practices are under quite a lot of pressure at the moment. Referrals into cancer services are at or above pre-COVID levels now, which is encouraging because certain cancers had fallen below the expected referral rates, and we were worried that there were people, particularly with head and neck and lung symptoms, that weren't coming forward and that might have problems that were more serious. We're developing new diagnostic pathways, but that might mean that some people need to go outside their area because we're using capacity of private sector and helping hospitals helping each other out. So again, I would encourage people, if they are concerned that they have serious symptoms and they find that they're being asked to maybe go to North Tyneside or across the river for an urgent test or investigation, that they don't delay that, or they try as far as possible to attend that appointment, because that means we get to a faster diagnosis and hopefully faster treatment. Diagnostic waits, clearly they're going to be impacted on by social distancing and cleaning of instruments and things like that. So again, we're having to discover new ways to try and screen for problems. So bowel cancer suspected symptoms always used to have a telescope test. Now we do something called a FIT test, where we take a sample of somebody's stool, and that can give us a very accurate indicator of whether it's a high risk situation or a low risk situation. So again, we're trying to use that to make our diagnostic services more efficient and not subject people to lots of invasive tests when there's something that can screen out those people that are very unlikely to have a problem. We've got a lot of people that are waiting more than a year now. So we have got about 7,000 people at Newcastle hospitals waiting for for 12 who have been waiting 12 months or more, but the numbers have started to come down now, thankfully. The biggest waits are for spinal surgery, and that's partly because everybody who has spinal surgery needs to have an intensive care unit bed, and it's treatment that can't be accommodated as easily when we've been trying to fight the pandemic. So that's the reason that has grown so much. But again, thankfully those weights are starting to come down now, but it's a considerable number of people, and we're very aware of that. Ophthalmology and dermatology, so that's eyes and skin, still has quite a lot of backlog, but I'm happy to report that the pop-up cataract hospital service is now underway, and that is on the Centre for Ageing and Vitality, or the old Newcastle General site. So hopefully that will be making quite an impact now into the backlog of people waiting to have their cataracts treated. And we've mentioned here that harm reviews are undertaken for long waiters, but perhaps the more positive way of saying that is that waiting lists are continually reviewed, and if there are problems, we're looking into them and we're addressing them proactively with the trust. A&E improved flow in the last month or so, with some decrease in waiting times. So the overall message in terms of hospitals is that things are improving. Long may that continue, and long may the Delta variant be held at bay and not result in hospital admissions, because that's the thing that will help our recovery most. And general practice is open, has always been, and if a face-to-face appointment is something that's required or even preferred, then the discussion with your GP will enable that to happen. So I'm happy to take questions. There may have been things coming in the chat that I've not spotted, but happy to take any questions if anybody has any.
Hi, Dominic. We do have a couple of questions in the chat box. The first one's from David. He mentioned an article that was in the Sunday Sun. And the article was entitled "Why City is Lagging in Vaccinations," and the Director of Public Health at Newcastle Health Scrutiny Committee on Thursday was reported to have said it was now thought that access to vaccination centres rather than reluctance to get the jab was the bigger problem. Previously, the issue was attributed to Newcastle having a large BAME community, but issues of lower car ownership and lack of public transport seem to be a big issue. And he's asking you, as medical director, do you recognise this as an issue?
Yeah, so yeah, it is an issue. It's more complicated than it might appear in the Sunday Sun. So I want to say specifically that the lag has been in cohorts 10 to 12. So this is fit, well people under 50 in the cohorts 10 to 12. So that is the only area that we appear to be lagging. And what we don't know is that, well, part of the problem is that we don't have all the data. So people that have been attending Centre for Life and other sort of large vaccination centres, the data isn't being fed through. So what we don't know is whether we do have actually the right number of people in those cohorts who have been vaccinated, but we're just not capturing the data. Or whether it's those younger groups aren't coming forward to have their vaccinations as enthusiastically as older people or people with other illnesses that were obviously prioritised in the earlier cohorts. And we do know that nationally, people from Black and minority ethnic groups have been more resistant in coming forward for the vaccination, again, for a whole variety of reasons, some of which are very justified. So in Newcastle, we've had a number of initiatives in Gateshead as well. So we've got vaccination buses going out to try and make access easier. Our bigger problem in some of the Newcastle vaccination centres has actually been getting people in. So we have been spending a lot of time on the phone, ringing people who we think should be coming forward for a vaccination. But all of our primary care networks and the Newcastle GP Federation and similarly in Gateshead have been working hugely hard. So nobody's taking their foot off the pedal, and the exact nature of the problem is still yet to unfold, but we are looking at it and working at it. Is that all right, David? Yeah, okay.
That's great. Thanks, Dominic. We have another question from David Forrester. He's asking, when will GP surgeries start using online booking of appointments? Since this service has been suspended, all patients must use the phone lines, which would need to be increased in number to compensate for the absence of online booking.
So again, I think it differs surgery to surgery. So some online booking is still possible. So I have patients that book online appointments with me, but not face to face, because what we need to do is just have a little bit of clinical triage for those face to face appointments, because if we can sort it on the phone, that's better. And what we don't want is those crowded waiting rooms. So if everybody was able to book a face-to-face appointment online without any filtering, we could easily end up in a situation that nobody would want, with either people queuing out the door or a full waiting room. So online booking is partially open. Some surgeries will differ the amount to which they've opened it, and some surgeries have more of a problem getting through on the phone than others. But I absolutely take your point. If it's a surgery that has too few phone lines, and phone is the only way to make contact, that's going to be frustrating, and it would be good to hear about those instances, and we can take those up with those individual practices.
That's great. Thanks, Dominic. Does anybody else have any questions they'd like to ask Dominic, either by putting your hand up or in the chat box?
And I'd also be keen if people were brave enough to just hear what people's, on the ground experiences are. So, I do practice as a GP still, but that gives me insight into one practice's patients and way of doing things. So very keen to hear what people's experiences have been of either general practice or hospital services. I can see, has Elizabeth got a hand up?
Elizabeth's got a hand up yet. Hi, Elizabeth.
Somebody, I'm not hearing anybody. So I don't know if Elizabeth, you've changed your mind.
Are you on mute?
Is that better?
Yeah.
Yes, right. I had a query about the digital data and the fact that all our records may be going into some big central digital pool, and the issue really of opting out. And I have read so many things about it, and I'm still not clear about how that's going to work, or whether in fact it's been decided whether they will go ahead with what's been initially proposed.
So this is very interesting, and it's quite controversial at the moment. I've put a link in the chat that anybody can have a look at, which explains how you can opt out. And there's two levels of opt out. There's a national data opt out, which is very easy to do. And it literally takes a couple of minutes, but they do have to send a code to your phone to check you are who you say you are. And you do need your NHS number in order to do it, ideally. But apart from those two pieces of information, it literally takes about 3 or 4 minutes to do a national data opt-out. There is also a more local type 1 data opt-out, where you fill in a form and you send it to your GP. But from my reading of it, if you do the national data opt-out, which means you don't want your hospital data, your social care data, or your general practice data being shared, I think the national data opt-out will suffice. You don't need to do two. If you're just doing your general practice data, then you do have to tell your GP, and you do have to fill that form out. Now, the British Medical Association has made representation in the last week or so to say that they feel that patients haven't really been fully informed as to what the benefits are of having this data shared in the first instance, but maybe what some of the consequences are of having this data shared. Now, the data is going to be pseudonymized, so that is different to anonymized. So there will still be some aspects of who you are, your gender, your age, and all of those things that will be there, but your name and your address will not, or your date of birth won't be attached to it. But that's not the same as anonymization, it's pseudonymization. Now, There are definitely some distinct advantages to knowing about the health of a population, to know what their major needs are, to what the health inequalities are. So there's definitely some advantages for the NHS in terms of planning of services and commissioning the right amount of services by using that data. But I think there are some genuine fears about that data being used beyond the NHS, not just for research, but by pharmaceutical companies and by private healthcare providers. I don't think that those concerns have been fully explored and addressed yet. So you can opt out or opt in at any time. So that's the other important thing to say. There's no deadline, but yeah, if you follow that link, it tells you what to do and how to do it.
Thank you. I have a further question, which is there a date by which each GP practice or whatever is meant to have turned over all the digital material?
Yeah,
and,
so
and
that's the 23rd of June.
That is the 20th, and then so that if, say, you say yes, you can opt out at any time, but supposing, you know, you're sort of behind time or whatever, and you choose to opt out, say, next September, does that mean that whatever information of yours has already been accessed by this bigger digital pool, you can't retrieve it back, presumably?
So there's two steps. So firstly, your practice has to turn on the sharing information. So the expectation is that practices will turn that information on, but with the amount of backlash that has been over the last week or so, there are certainly some groups of practices. So in some of the London areas, there are groups of practices who are all saying they're not going to turn it on. We've got one practice in Gateshead that has already unilaterally decided it's not going to turn it on for all of their patients. So, you know, that may still have quite an impact. But we don't know what all of our Newcastle Gateshead practices are going to be doing yet. But if they do decide to turn it on and you haven't done an opt-out on the 23rd of June, then your data up until that point will be shared in a pseudonymized form. So if you don't want that to happen and you're not quite sure what your practice is going to do in terms of turning it on or turning it or leaving it as it is, which is off, the default is off, then you do need to do that before the 23rd of June.
Right. Okay, that makes sense. Yeah.
Okay.
Our practice has done something on their website about this, but the implication is, yes, you can opt out at any point, but what you've just addressed isn't on there, and I think that's important. I mean, the fact that, you know, if it all gets turned over on the 23rd, that's it, and any information about you after that that you wish to prevent having that happen to, so you opt out. Nonetheless, that basic information presumably is there forever on this. Yeah.
In a pseudonymized form.
Yeah. Okay, thank you. That's very helpful.
Okay.
Thanks.
And I think I've got Kate and David, is that right?
Yeah, that's correct. I'm sorry, I'm not sure who raised the hand first.
Dominic, it's Kate, sorry. Can you just explain pseudonymized again?
So anonymized means that they don't know, they can't tell anything about you at all, your age, your gender, which part of the country you're from, etc., etc. So clearly there are some disadvantages to that, to just having sort of human level data and not knowing whether it's children, adults, people from different minority ethnic groups. So to pseudonymize, they will apply a random sort of name, but they will know your age, they will know which part of the country you're from, they will know your ethnicity if it's recorded in your GP record. So it's not quite anonymous, but you should still not be able to be personally identified.
Okay, and how do they treat? Okay. So I think I've missed something here, which is when exactly when exactly as a patient do you find out from your GP that they're going to share your data? Do you find out before it's happened?
Well, other than what's been in the media about this, so this isn't new, I guess. When I used to work for NHS England back in 2013, this was just starting. So it's been around and it's been discussed and it's been in the media since then. Now, the sort of positive spin on this is that our National Health Service, because it's a nationally commissioned service, and because we code data in general practice specifically, we don't code nearly as well in hospitals, but in general practice we code amazingly. We have probably in the whole world, we have the best health data set that any country has, and we could use that very helpfully to plan care, to plan treatment, and to improve the health service in very significant ways. So there's been a move afoot for many years to exploit that data to its full potential, which we absolutely don't at the moment, and that's where this has come from. But yeah, if you don't do your opt-out before the 23rd of June, and if your practice switches on as they've been instructed to do, your pseudonymized data will be shared. I don't think NHS Digital have done a good enough job at communicating with the public about this, because it's seen all the advantages and hasn't recognised many of the fears. But on that website link I give you, there is a lot of, addressing the false information that has been sort of, shared and things like that. So hopefully it'll answer some of your questions, but do follow the media it's a national diktat rather than a local one.
Thank you. That wasn't actually my question. It was just a follow-up to what Elizabeth was saying. So it wasn't actually a question, it was an observation that I have several friends who, when they were told you can now make your appointment for your COVID vaccination, when they tried to book it in, you use their name and then their date of birth, they were the website actually said, no, you're not eligible. And I've had several friends who did this several times and got knocked back, and then it took them maybe 3 weeks to be eligible to get an appointment, even though they were in the catchment. I forget whether they were in tier 12 or whatever they were, but so, and they phoned their GPs, and their GPs said, well, we're not managing this, it's being managed through a central system. So they were kind of lost and had to just keep trying each day. So, there's something strange happened there, because it didn't seem to happen for the over 50 age groups.
Yeah, so there've been lots of frustrations with the national booking system, including people having to travel to Keswick to get their vaccine, and to outer reaches of the northern region. But the reports I'm having in the last week or two is that a lot of that now has been ironed out. So apologies for the frustration, even though it's a system we've not commissioned or ran. But hopefully you'll find it's running a lot more smoothly now. And certainly people, there were people whose second vaccines weren't for quite a while, and they found that if they went on and rebooked, it was brought forward. So, it has definitely been full of gremlins, but hopefully a lot of those have now been ironed out. So David, were you next?
Yeah, I just want to give you some feedback. You're asking for feedback.
Yes, absolutely, please.
Yeah, just very briefly. I look after an 85-year-old gentleman who's my neighbour in Newcastle. About a month ago, he had 5 days of diarrhea. I went to the pharmacist and they give us some electrolytes to try to get his liquids and things back up. And they said he must speak to a GP that day. So at 10:30, we called his GP surgery. This was in the morning. And he got a call back at 5:30 by an unnamed GP. And his statement to me was he could have been dead by then. so he isn't very impressed with that surgery at all, and just the fact that they seem to have forgot about him. He's got a lot of long-term conditions, heart problems and diabetes, and they're not sending. He used to be getting blood tests at the GP surgery, and they haven't bothered for a year. And then just a second one, which is a different GP surgery, which is my GP surgery. You can't book online, but more concerning is, as someone with a rare condition, I wanted some reassurance from my GP practice, not a GP, just a nurse, before I had my jab. And all I kept getting was the national system, and the GP surgery actually rung us up and I said, I'm prepared to come to yourselves to have a chat, but not, I don't want to go to a national centre. And I was told, if you don't accept the vaccine at the national centre, you go to the back of the queue. So I've managed to get on a clinical trial at the Freeman, and on the 13th of May, I was injected with something. They looked into my medical history and they said it wouldn't affect us getting involved in the trial. And it's either a new vaccine, an experimental one from a company called Valneva in Austria, or the AstraZeneca. And because it's a blind trial, none of us know. So I had my first vaccination of something on the 13th of May, and I get my second on Thursday, which is 28 days later. So really, I just feel let down by the system. And I know what they'll say, that, you know, it's a national thing and you should have just went to the national centre. But the way I sum it up is, I wanted some reassurance, I wanted some care by the system. I've had that care now by a consultant who's running the clinical trial at the Freeman, and I've got his phone number. Because it's a trial, if anything happens to me, I can immediately contact someone. I can't contact me GP. And I've ultimately had to like game the system to get injected with, I may or may not be protected.
Yeah, so I'm sorry to hear your frustrating experience, David, and I understand that reassurance you were seeking wasn't forthcoming. And whilst it's difficult to comment on yours or your neighbours' clinical cases, not having been the doctor involved, you know, what I would say is that I think some of the difficulty with some of the vaccine concerns is that many of us GPs didn't know the answers to some of the questions we were being asked, because this was a new vaccine. You know, it had only been around for a few months and we didn't really know what the safety profiles were. And of course, we've seen with the AstraZeneca vaccine in certain age groups, there are some concerns that have only emerged since the vaccine rollout. So some of it might have been that people just didn't know, but that's no excuse for not having a conversation with you to say they just didn't know. You know, you're very much at liberty to you know, raise that issue with the practice,
well,
and say that you weren't happy.
This would be my third complaint, and they just knock us back. So I feel like I got wrong from the GP years ago, because I'd never visited the surgery for 16 years. And I feel like it's going to probably be another 16 years. I've got a cardiologist looking after us at the Freeman, and I've got a genetic consultant looking after us at the Centre for Life. Trying to access the GP, it's hopeless.
So, you know, again, GPs are independent contractors.
Yeah.
And they receive most of their income through a contract with the NHS that we commission on your behalf. But if people aren't happy and the complaints process hasn't delivered the changes that they're seeing, my recommendation to any patient would be take a recommendation from a friend or neighbour or a family member as to a practice that might meet your needs better. and it's actually quite a simple process to move practices. But if using the sort of agreed channels isn't delivering what you would expect, then I would encourage you to sort of, you know, look sideways and see what else is available.
Okay, thanks very much, Dominic. Thank you very much.
That's great. Thanks, Dominic. The only thing I want to mention is been a couple of comments left in the chat box. The first one's from David Forrester saying I can't even say it. Pseudonymization. Yeah, get my teeth in. Can be returned to data that identifies an individual by NHS Digital. He was just wanting to let the group know that. And Terry's also commented that the original version of this was finally called Care Data and was halted in 2009 due to massive patient backlash. This is mentioned on the website, but the only difference seems to be that this is not for profit. It's not for profit version. So just to acknowledge those two comments.
Yeah, so they were going to sell the data initially. They were going to share the data for free now, but it could still be with commercial organisations outside the NHS.
That's lovely. Thanks, Dominic. I think everybody's had the questions answered, and I'd just like to thank you on behalf of the group for coming today and for your presentation. I'm sure we've all found it really useful. So thanks again, Dominic.
That's a pleasure. I need to pop off for another meeting now. Is that okay?
That's absolutely fine. We're finishing now anyway. We've just got one more slide to go.
Okay, thanks. Thanks, everybody. Thanks, Kirsty.
Thanks, Dominic. Bye.
Bye.
Hi, everybody. Apologies that we're running slightly over. Just want to highlight that the date and time of the next meeting is the 5th of July between 10 and 12. As we've explained at previous events, we are in the process of moving to place-based forums, so we'll keep you updated. But at this moment in time, that date still currently stands. But if there's any changes, you'll be the first to know. And the last and final slide is I'd just like to say thank you to all the speakers that's presented today. I hope you found it all useful. And Hannah did put the link to the Survey Monkey in the chat box over the break, which she'll be doing it again at the end of the session. And I would just encourage each and every one of you to complete the survey because we do value your feedback. We'll also be sending the link to the survey out via email if you don't have time to complete it today. And as I say, that your feedback really helps us to learn and how we can improve things moving forward. And just encourage you to complete it as soon as possible. And we will be publishing this recording on our website, which then allows other members of the public to view it or yourself at a later date. So once again, thank you to each and every one of you for attending the session today. I hope you found it useful, and we look forward to seeing you all again.
Thank you.
Thanks, everybody. Bye.